The speaker for this presentation is Andrew Levey.
Hi everyone, I'm Andy Levey from Tufts Medical Center, and the topic of my presentation is defining AKD, the spectrum of AKI, AKD, and CKD. It's a lot of initials, but I know you all know what they mean. The advanced materials for the conference said that the topic of this presentation would be defining AKI, but that was an error. We've corrected it in the final materials, but just in case anyone is confused, I am planning to talk about AKD. If we have time, either at the end or during the questions, we can talk about AKI definition. Here are my disclosures. I'll be talking to you today about the proceedings from KDIGO Consensus Conference on harmonizing the acute and chronic kidney disease definitions and classifications. The conference co-chairs are listed here. The KDIGO co-chairs are listed here, and the KDIGO CSO, together with all the co-chairs, will be the authors on the final document. I'll point out that Adira Levin and Paul Stevens were the KDIGO co-chairs who chaired the CKD guideline update from 2012. And Norbert Lemire and John Kellum were the KDIGO co-chairs who chaired the AKI guideline from 2011. So this really brings together the old team in order to talk about harmonizing the definitions. The conference was supposed to be held in Toronto, but because of the COVID pandemic, was delayed and then became a virtual conference. So here's the picture of our group. Nobody looks as good in these pictures as when we actually pose and stand together. The conference objectives are listed here, and I will be talking about the ones that are highlighted in red: to revisit and refine the AKD definition and classification suggested in the 2012 AKI guideline, and describe the relationships among AKD, AKI, and CKD. It was an objective to develop evidence-based management recommendations, and the publication will have some management recommendations, but we won't be going over these today. Because we were meeting virtually, it restricted us to a relatively small group of investigators, including those who have published on the topic and representatives from the past guideline work groups. And we did have some original data presentation, and I'll show you just a snippet of that information that was presented. We said ahead of time that we will not be writing a new guideline or revising the old guideline for AKI, that we won't be writing graded recommendations or practice points, and will not be revising the KDIGO definitions of either AKI or CKD. So we're just dealing with the AKD definition. Doctors Levine and Kellum and I wrote an editorial back in 2013. I was the guideline chair for the 2002 KDOQI CKD guideline. So we thought that this group of us had a fair amount of experience in defining conditions for guidelines. And we thought we should point out the rationale for developing guidelines and classifications anyway. It's based on the idea that the uniform terminology and explicit and objective criteria can enhance communication, awareness, enable earlier detection and intervention, and ultimately improve outcomes. We wanted to point out that kidney disease is defined as a heterogeneous group of disorders affecting kidney structure and function, irrespective of their duration. It's recognized now that even mild abnormalities in measures of kidney structure and function are associated with increased risk for developing complications in other organ systems, as well as mortality. And these complications occur far more frequently than kidney failure. This is true for both CKD and AKI. Currently, KDIGO classifications do define and classify CKD, define and classify AKI, and they suggest the definition of AKD and disorders. They do not define recovery and resolution of AKI. They don't classify AKD, They don't define kidney diseases and disorders irrespective of duration, and they don't define the absence of kidney disease or disorders. Now, ADKI 16 did come up with an alternative definition of AKD that was linked to the recovery and resolution of AKI, which they defined, and they classified AKD. And I think this stimulated us to get together quickly in order to avoid the ambiguous situation of having two different definitions and to try and see what about the ADKI definition we would propose and what we wouldn't propose. Now, let me take a step back that I think a proper disease definition for guidelines should include a conceptual model, a definition in words, and the criteria. Since we have such a short time, I'll just say that the conceptual model for CKD and AKI are very, very similar and lend themselves to the similar conceptual model for AKD. I'll be talking about the definition and the criteria. Now, let's just make sure we're all on the same page, what we mean by some terms. So the term disease, according to Wikipedia, is an abnormal condition that negatively affects structure or function or all of part of an organism. Disorder is a functional abnormality. Acute in medicine means short duration, recent onset. Chronic means it's persistent. And the similar definitions are used in other online dictionaries such as Wiktionary or Oxford via Lexico. Now, when we classify a disease, we classify a disease along numerous axes. There can be a classification according to structure, according to function, according to outcome, according to cause, and most importantly, for this discussion, according to duration. Doctors Levin and Kellum and I did not include classification according to treatment and response, which should be on the slide, so I've added it here. And as I've said, we're now talking about disease duration. Now, why is it important to define and classify AKD separate from AKI and CKD? And it's because some patients with kidney diseases and disorders don't fill the criteria for either AKI or CKD, yet they require medical attention. And without a definition for what they have, there's a gap between AKI and CKD, which is conceptually illogical, leaving patients in a gray area without a valid label and without management recommendations. And this wording is from the scope of the conference published ahead of time. So let's think of examples of acute kidney diseases and disorders that might not fulfill the criteria for AKI. And by the way, if they don't last for more than 3 months, these are acute, they won't fill the criteria for CKD. So how could these diseases, which are part and parcel of what we take care of every day, not fulfill the criteria for AKI? Well, it would be because they're not accompanied by a GFR decline, or that it's before there's sufficient GFR decline to fulfill the criteria for AKI. Now, they might never fulfill the criteria for AKI if the GFR decline is too small or too slow. Note also that these diseases can all be superimposed upon CKD of other causes. So we have to have a way to recognize these diseases if they don't cause a GFR decline sufficient to fulfill the criteria for AKI. Now, these diseases can be characterized by markers of kidney damage, and others are characterized only by decreased GFR. So these are the diseases we don't want to miss. So here are the KDIGO AKI guideline criteria for AKI and AKD. AKI, you know, it's an increase of serum creatinine by 50% within 7 days, by 0.3 within 2 days, or oliguria for more than 4 hours. The criteria for AKD are any of the criteria for AKI, or a GFR less than 60, or a decrease in GFR by 35% times the baseline, or an increase in serum creatinine by more than 50% times the baseline. These are all functional criteria. The structural criteria are undefined for AKI. There are no structural criteria that meet this requirement. Okay, these are functional criteria. But for AKD, markers of kidney damage, such as albuminuria, hematuria, or pyuria, would fulfill the criteria just as they do for CKD. So these were the criteria advanced by the KDIGO AKI guidelines in 2012, and it was confirmed by the small group of us that met that we wanted to continue to have these as the criteria for AKD, and therefore that AKI is a subgroup of AKD, right? Because anyone with AKI meets the criteria for AKD. And the main differentiation between AKD and CKD is the 3-month cutoff and creatinine criteria independent of GFR criteria. And if you don't meet the criteria for any of these, we say there's no kidney disease. I like to call this no known kidney disease because, of course, how far you evaluate a patient for markers of kidney damage depends on your suspicion for the disease. So here's a paper by Matt Janes that I participated with and his colleagues at the Alberta Kidney Disease Network on the incidence and prognosis of AKD using an integrated approach to laboratory measurements in a universal healthcare system, and that's in the province of Alberta, Canada. We used these criteria to define AKI, CKD, AKD, or no kidney disease. These are the same criteria as we're recommending. And here's the incidence of AKD and disorders. In the dark are using as the denominator the residents of Alberta who were tested in 2008. And in gray are the residents in Alberta in the census. And you can see that AKD occurred in 3.8% of those people who had tests of kidney function, such as creatinine tests or urine protein measurements. Far less common than people with CKD, in whom it was 10%, but 3 times more common than AKI, in whom it was 1.4%. The combinations of CKD and AKD were even less common. CKD and AKI are listed here. So this is a common disorder. Now, you may say that, it was an AKI, but you missed it. But that's okay, because if you missed it, you can't call it an AKI. It may be the same disease, may even be the same episode, but if you missed it, you can't call it AKI. That's even more important, right? If you can't call it CKD and you can't call it AKI, right, then you're missing all of these. Now, what's the prognosis? Here are the cumulative incidence curves for mortality, CKD development, CKD progression, and end-stage kidney disease for these disorders and combinations. So here's CKD, the blue line. Of course, having CKD is associated with an increased risk of mortality compared to no kidney disease. And AKD is just about as bad. AKI is even worse, right? CKD and AKI is worst of all, but CKD and AKD is as bad as AKI. So having AKD is clearly not irrelevant, okay? It does have implications for health. Here's the risk for CKD development. If you have AKD, you have a higher risk than if you have no kidney disease. Here's the risk of CKD progression. So everyone's starting with CKD, but if you have CKD and AKD, it's just as bad for CKD progression as if you have CKD and AKI. And here's the risk of end-stage kidney disease. Here's CKD, right? AKI, AKD, and it's higher than NKD. So this suggests that AKD is not only more common, but it's more serious. That's my timer. So I'll finish up quickly. Here's our proposed conceptual model for the continuum. Kidney disease includes both acute and chronic diseases. It has a theoretical time that it starts, and it progresses this way. AKD is the first 3 months of CKD. AKD may be initiated by an event which causes AKI, or there may not be AKI at the beginning. AKI may develop at any time during the AKD episode, and either AKD or AKI can develop along during the course of CKD. Just as final few slides regarding naming. Here's what we say in words for the CKD. It's a disease defined as abnormalities of kidney structure and function for greater than 3 months with implications for health. We propose that we adopt the term kidney disease to mean the same thing, except we eliminate the requirement for duration. Acute kidney disease and disorders are kidney disease and disorder defined as abnormalities for less than 3 months with implications for health. AKI is a subgroup of AKD defined by alterations in kidney function over 6 hours to 1 week with a duration less than 3 months. We didn't say this before, but it was inferred. And AKD without AKI is a subgroup of AKD in which the alteration in kidney function is not as severe or does not develop as rapidly as in AKI. NKD is no known structural or functional alterations of the kidneys, meaning it doesn't fulfill the criteria for AKD with or without AKI or CKD. And then this is our conceptual overlap, that AKD and CKD you start with AKD, you develop CKD, but then you can have AKD superimposed on CKD. AKI is a subset of AKD, which also may be developed, superimposed on CKD. And this will be my final slide, and I hope that there are time for questions. Thank you very much.